All right. So if a randomized trial is the gold standard, then some of you had asked me, oh, but why do we even do observational studies? Well, a gigantic share of epidemiological research that is ever done is all non-randomized, observational. Randomized trials are not the norm when it comes to epidemiological studies. Why? A, because randomized trials are ridiculously expensive and difficult to do for all the reasons we just spoke about. And B, there are many, many situations where we simply cannot ethically, morally randomize people to a certain exposure, right? If the exposure is smoking, if the exposure is air pollution, if the exposure is obesity, if the exposure is physical activity, we cannot randomize people realistically to any of them. All we can do is observe those exposures and then see, is that associated with future development of risk or not? And the best design to do that among all observational studies, the strongest design is the cohort design, right? And I already told you where the term cohort comes from. It comes from the Roman military structures of soldiers moving forwards in time, right? So simplistically, you begin with a population at risk. In other words, they should be at risk for developing whichever disease that you're interested in, right? If you're doing a cohort study on developing measles, don't start off with a bunch of kids who've been vaccinated with measles because it's a waste of time, right? You won't see enough measles in that cohort. You need a bunch of kids who haven't been vaccinated with measles vaccine, and then you follow up to see what happens to them. So start with the population at risk. Second, measure covariates at baseline, both the exposure factors as well as a bunch of potential confounders and covariates. Measure all of them, and then you just wait. Track that cohort over time to see what happens to them. How many of them newly develop the disease that you care about, right? You can also do multiple re-examinations of the cohort, right? Every year, we will call you to the clinic and we will get an ECG on you. We will do a chest x-ray on you. We will get your cholesterols done. We'll check your blood pressure and so on and so forth. Multiple re-examinations can be done. We keep track of attrition, which means people who disappear from the cohort. We keep track of people who withdraw from the study and they say, no, we don't want to be participating anymore. We can look at dropouts, and then we can look at competing risks. If somebody died of, if you're following up for heart attacks or heart disease deaths, but somebody dies of a traffic accident, you still need to track those competing risks or other risks. And when you're done with all this, you will be left with incidence of the disease in the group that you define as exposed. You can compare it in incidence of the disease in the group that is non-exposed. You divide one by the other, you get the incidence risk ratio or the incidence rate ratio, right? Then you would adjust for confounders, come up with an adjusted incidence density ratio. If you did all this, you would have done the best cohort study anybody can potentially do, okay? It's a lot of work to do a cohort study, often quite expensive, but can be very rewarding in terms of the richness of data that it can generate, right? So basically, a cohort is a total group that you're following up, which you would automatically get separated into exposed or unexposed. For example, smokers, non-smokers, and you're following up for COVID-19. You look at the disease events that happen in both groups. You track the people who left or died, and then you finally compute the incidence of COVID-19 in the smoker group, compare it to the incidence of COVID-19 in the non-smoker group. Now, this is a simplistic understanding of a cohort, but in reality, as we showed you last week, it's actually much better to think of a cohort as a group that's moving forward in time, different people entering at different times, different people potentially leaving, people developing the disease, people dying of something else, and everybody, so long as they are contributing to a person time follow-up, is a useful member of the cohort. So we take everybody's person time contribution, we aggregate it and we sum it. That's a total person time follow-up of the cohort, and we see how many incident events happen in that cohort. You divide one by the other, you get the incidence rate or incidence density, which is the most superior technique for measuring disease events in any cohort. Okay, this is the gold standard of how we think about a cohort study. So cohort studies can be large, can be small, can be long duration, can be short duration, can be simple, can be complicated, can look at multiple exposures, multiple outcomes, can look at changes in exposure over time. We call that time varying covariates, right? Covariates change over time. Can look at very rare outcomes, but it will require us to study large number of people for a long period of time. Usually expensive because many people need to be tracked. But once you have a cohort up and running, you can sustain it, then you can get very rich data for a very long time. Here is a beautiful example. Everybody in the world knows the world famous Framingham heart study. Framingham is a small county in Massachusetts, not far from Boston. Okay, so years ago, in the 1940s, the NIH decided that they're going to pick Framingham as their site for heart disease. At that time, I'm talking about the late 1940s, nobody quite knew what was the biggest risk factors for coronary artery disease. They didn't know it was cholesterol. They didn't know whether it was family history, whether it was obesity, whether it's hypertension. So they said, let's do the study, right? So they recruited people in the Framingham heart study, hundreds and thousands of people. They got them all. They did a whole bunch of baseline measurements on them. And they said, every 2 years, you come back to us. We will do all sorts of basic tests on you for free, okay? And patients, people in that little town enjoyed being part of the study. They wanted to contribute. And that led to this massive database of people followed up over time. And now they've had 3 generations of people in Framingham town who participate in the study. Here's a great grandfather, father, and son all participating in the Framingham heart study, right? So basically, they had the original cohort, then they did something called an offspring cohort of their children and their children's children. And they're called Gen 3 cohort is now currently under follow-up, right? It has produced incredible information. In fact, most of what we know about the natural history of heart disease, what are the risk factors, comes from this amazing Framingham heart study. Okay. Now, how are cohorts assembled? Could be a geographical region like Framingham, could be an occupational group. The British Doctors' Health Study is a very famous study. The American Nurses' Health Study has thousands and thousands of American nurses who are part of the cohort study. You could have a disease cohort like the AIDS cohort. You could have the San Francisco Gay Men's Health Study, which follows up a whole bunch of gay men over a period of time. You could have an exposure event that defines the cohort. For example, you have a cohort of people who are exposed to the Bhopal gas tragedy, right? That's a well-defined cohort. Where you in Bhopal that morning when the Union Carbide explosion happened, where you exposed, and what is happening to you over time. And I know people who've done that sorts of studies in India, right? Every opportunity, like this Fukushima disaster, where there is a nuclear meltdown, all the people living around Fukushima could be recruited because they were exposed to radiation, and you could follow up them to see what happens longitudinally to their reproductive health outcomes, to their mental health, to their risk of various cancers, so on and so forth. Typically, what you could do is you could start with a cross-sectional study, which I will explain in the next class. And then if you repeated the data in the same cross-sectional group after a time period, then you successfully converted a cross-sectional study into a cohort study. For example, years ago, this was a paper, the study that I did in Sevagram in India, published in JAMA, where we recruited healthcare workers at the Mahatma Gandhi Institute of Medical Sciences, and we tested them for TB infection, right? I had over 700 healthcare workers in my study. That was in 2005. But then I went back a year or two later, and we repeated the test in some of them. So what I had in 2004 and 5 was the baseline TB test information in them. Now, when I went back and I repeated the test, I could see how many people who were negative 2 years ago have now converted their skin test and become positive. Now I get a truly new information called incidence. And the baseline cross-sectional survey, all I could get was prevalence. But by going back and surveying them, I successfully converted my cross-sectional study into a cohort study. And then years later, 5 years later, we went back to them to say, have you actually developed active TB? Through telephone and email, we followed up these participants. Now we've converted that into an even longer follow-up cohort study, right? So when you do multiple looks at a population, and if you can follow up a population over a longer period of time, you can convert a cross-sectional, original cross-sectional design into a cohort design. And you can use multiple methods to collect your exposure status and your outcome status. You can look at health records, you can look at medical records, you can look at birth and death statistics, you can look at databases for medicines, you can interview people, you can telephonically contact them to see what happens to them. They're all techniques we use in cohort studies, okay? There are two variants in a cohort study, right? What we call prospective cohort study or a retrospective cohort study. And if you did both in the same study, you could do something called ambidirectional cohort study, okay? Let me explain this graphically. It looks complicated, but it's not, right? So a prospective cohort study would be, let's say we are now in the year 2008. We define the population and we find them automatically to be exposed versus non-exposed. We did not assign the exposure, right? Because this is a cohort study. So we check on them. Let's say we're looking at smoking and lung cancer. We take a bunch of people, we survey them, we check whether they have cancer at that time or not, and then we also ask them about their smoking history. Then we, the researchers, we just stick with this cohort. We wait, right? After 2 years, 5 years, 10 years, we go back to the same people, and now we check whether they've developed lung cancer or not. We began the study, we collected the exposure, we made sure they didn't already have the disease. Then we stuck with this group over a period of time, and we've collected now the outcomes after a few months or years. If we did that, we would have done a true prospective cohort study, right? We started with the exposure, we waited it out, and we collected information in follow-up. That's why it's called a prospective cohort study, right? Now, sometimes, and I'll give you an example right now to make this clearer. So they have launched a study called Inter-COVID on COVID-19 and pregnancy outcomes. Now imagine the crazy situation we are living in right now. Whole bunch of people have developed COVID-19, including pregnant women right now. I mean, thousands of pregnant women in US, UK, Germany, France, Italy, they've all had COVID-19 while they were pregnant. And I'm sure every one of them is asking, I've just had a viral infection, a pretty nasty virus by all counts, and a new virus. Nobody in the world knows whether my baby will come out well or not, right? When I deliver, will the baby have congenital malformations, right? Will the baby be born preterm? We have zero idea at this point. Nobody in the world has enough accumulated experience on what happens if you're pregnant and develop a clinical confirmed COVID infection, right? Especially if you developed COVID infection in the first trimester, where the risk of congenital malformation is very high. Nobody in the world has any clue. It's an incredibly complicated moral dilemma to know what on earth to tell someone, will I be okay? We don't know, right? So here's what they're doing. They're doing this large multinational prospective cohort study with the aim of assessing the effect of COVID on pregnancy and maternal, fetal, and neonatal outcomes worldwide, okay? Gigantic study, massive study. So exposed cases for them are pregnant women who've had lab-confirmed COVID-19. Each exposed case will then be matched with 2 non-exposed pregnant women considered representative of the pregnant population at each site, right? So you have a exposed case, which is a pregnant woman who had COVID. Then maybe in the same maternal health clinic, they could pick a couple other pregnant women, but make sure they've not had COVID, right? And you recruit them. And then you just have to wait it out, okay? You have to wait until delivery until abortion, until preterm delivery, or whatever it is, the natural history of the pregnancy is going to play it out, right? And then they're going to compare whether the pregnant moms who had COVID-19 have a substantially higher risk of, say, preterm birth as compared to the non-COVID exposed pregnant women, right? So based on the sample size that they've computed, they think they would have 80% to detect a 10 to 15% difference in preterm births between the exposed and the unexposed groups, with 500 exposed women and 1,000 non-exposed women. That's the sample size in this cohort study. Okay, and I predict we will see the results of this study by next year. There is simply no way to fast track this, right? You have to wait and see, enough events have to happen, and then they're going to compare the exposed and the unexposed women. Really important study, but right now we don't have the data. We'll have to wait till next year to see how this cohort study plays out. As you can imagine, there's zero chance of doing a randomized trial in this situation, right? Because this is not an exposure you want for any mom. You cannot randomize people to COVID or no COVID. You only can follow up a naturally occurring infection and see whether moms exposed to COVID will have a worse outcome or the same outcomes. I'm hoping that COVID doesn't do anything to the babies or the moms, but that's just a hope, right? Let's see what this virus does to the fetus. Okay, so that's a prospective cohort study. So these investigators started with exposed moms, and they're going to stick with this cohort until next year, right? So the results will be only available in future, right? You could also think of a shortcut design, but still with the same essential cohort design in mind, right? Now, let's say you begin today here. Instead of starting in the past and then following up period over a period of time, you begin now, right? Let's take the Bhopal gas tragedy. You could have started following up gas exposed people in Bhopal from the 1980s and follow them until today, right? Alternatively, you could go to Bhopal now, pick up a whole bunch of people with various outcomes, and then track back, if you had records, on who was exposed to the gas or not exposed to the gas. But you still would analyze them as if you stuck with them right from the gas exposure to today. You would still compute a risk ratio. You will still analyze it as incidents, but your technique for getting this has been shortcut. You start off with a bunch of cohort of people, you assess whether they have cancer today or not, but then you go back and collect the exposure history from the past, right? That's why it's called a retrospective cohort design. Right? Here is an example of a retrospective cohort design in this COVID outbreak. Association of treatment with chloroquine or azithromycin with in-hospital mortality in patients with COVID-19 in New York State. Okay, retrospective multi-center cohort study of patients from a random sample of all admitted patients with lab-confirmed COVID in 25 hospitals in New York. Right? Exposure they're looking for is whether the patients got chloroquine, azithro, or both, or neither. Primary outcome was in-hospital mortality. Okay, so basically what they did was they went to these hospitals. They said who all in this hospital has lab confirmed COVID, and then who died, who didn't die, and then they look back at their medical records. Were these people on any of these medicines? Hydroxychloroquine, azithromycin. Nobody was randomized to anything. They just looked to see what they were naturally getting in terms of these medicines, and they still analyzed it as a cohort study. Okay, and they found that the in-hospital death risk rate ratio, written as hazard ratio here, is 1.35 for, say, hydroxychloroquine alone versus neither drug, right? 1.35 for hydroxy plus azithromycin, which actually shows that it's dangerous, but statistically not significant, right? So the conclusion from this study was neither drug made any difference to the mortality. Some hint of a harm for outcomes like cardiac arrest or abnormal ECG finding, right? Now, in a cohort study, you will invariably see this analysis, and you already saw it in the previous slide. When you see the word hazard ratio, and when you see something like a Cox proportional hazards model, then you immediately know that what they're talking about is this analysis. This family of analyses belong to a statistical technique called survival analysis. Survival analysis. You begin with a cohort, and then you see what happens to survival over time, what happens to mortality risk over time, right? And the historical origin of survival analysis comes from actuarial statistics. My dad was a life insurance agent in India, right? Life insurance people live by actuarial statistics. That is how they know how to set the premium for you if you are 55 years old, you're a woman, you're a non-smoker, because they have done the math to see your risk of surviving until 70 is this much, right? Actuarial statistics is also called life tables. They take a person's age and they break it up into smaller chunks and then see who is alive at the start of the age interval, who is alive at the end of the age interval. So let's say it's a 2-year age intervals. You start at the age of 40, then who is alive up to age 42. Then conditional on reaching 42 successfully, you then enter the next row in the life table, which is 42 to 44, then 44 to 46. You break it up into multiple smaller chunks and you compute conditional probabilities of surviving each. So at each point, if you have successfully survived this, you enter the table at the next age category. And at each time, you check whether you die or you have still in the cohort or not. And then you accumulate them over all the age categories to get the overall survival probability, right? That's why when you talk to demographers, they use terms like life expectancy at birth, right? Life expectancy at birth is very different at life expectancy at the age 60. Right? Because to compute life expectancy at age 60, you should have already successfully survived up to 60 to even to be able to compute that, right? That means you're already lucky enough to survive 60. Your probability of surviving up to 80 is very different from a baby who's just been born, right? So survival statistic analysis, actuarial statistics, life tables are all examples of survival analysis. And the Cox proportional hazards model, also called a Kaplan-Meier analysis, you will see this jagged step line because the numbers jump at each day or time chunk. You break up time into small chunks and then you let the curve jump in terms of your survival or death. And generally, you're looking to see whether these curves, the hazard curves, diverge sufficiently between two groups or they're too close, so statistically significantly not different from each other, right? And so that's basically what the kind of analysis that these guys are trying to do. In an ideal world, you should also have 95% confidence bands around each of these survival curves to see whether they overlap or not. But I just wanted to kind of make you guys understand how cohort studies and randomized trials think about analysis. Survival analysis is a key critical statistical approach to dealing with how events accumulate over time and at what rate new events accumulate over time. So what are the areas where bias can appear in cohort studies? We've already discussed this in the past. It's the same 3 categories of bias. You can have selection bias, you can have information bias, you can have confounding in a cohort study. Here's an example of selection bias problem. So here is a cohort of AIDS patients being followed up over time to see whether they live or die, right? But turns out that not all AIDS patients are the same. If there are HIV positive patients who are also injection drug users, invariably they dropped out of the cohort at a higher rate than all other HIV positive patients. Now, when people drop out of a study, it produces an enormous dilemma for the researchers. Let's say somebody drops out of a cohort study, and they will drop out. It's merely a matter of how bad it is, right? If people dropped out, do you take it that they're okay? Or do you take it that they dropped out because they fell sick? And this is a huge issue because you have no information on what happened to them. And now you decide, if you just excluded everybody who dropped off, you're left with a very sanitized group that has stuck with you. And I promise you, that group that you're faithfully reporting to you will not be the same profile as those who dropped out. People drop out not for random reasons, but because they're sick, because they cannot tolerate the medicines, because they've suddenly become homeless, because they are in jail. There's a whole bunch of reasons why people drop out, right? And if you're not able to account for that, you end up with a selection bias in your cohort, right? You left with a group of people in your cohort over a longer period of time who are systematically different from people who dropped out of the cohort. So in this case, IV drug users invariably dropped out because of their HIV-related complications. And if you took them off in your analysis, you will get a very different result on what is happening in your cohort as opposed to keeping them in your analysis. One way of handling these kinds of headaches is to do a best case, worst case scenario analysis. If everybody who dropped out actually died, this will be the total death rate in the cohort. If everybody who dropped out was a best case scenario, none of them died, then this is the outcome in the cohort and the incidence in the cohort. And then you can compare the best versus the worst case scenario outcomes. And if they're vastly different from each other, then you need to really say that we have a problem. We're not quite sure what to do because we are getting a very, very different answers depending on how we treat those who dropped out of our study, whether they got it or they didn't get the outcome. You can also have information bias in a cohort study. Remember, at the start of a cohort study, nobody should have the disease. Everybody should be at risk for developing the disease in future. So we clean out the cohort and we remove already existing cases, and then we follow up over time. And we invariably document exposure first, then we wait for the disease events to happen in future. That's what makes it a cohort, right? So generally, exposure is not the problem in a cohort study because we are getting exposure status without knowing who's going to develop disease in future, right? Everybody in a cohort study, nobody knows who's going to develop cancer later on. We can only document the exposures now. The problem really happens is when we start looking for outcomes. If we're looking for outcomes and we know somebody has been exposed, we already have that information, we could differentially probe them for outcomes, right? For example, let's say I'm doing a study on smoking and lung cancer. Can I do more tests among smokers to see if they have cancer and do less tests on the non-smokers? If I differentially probe them, then I'm introducing an information bias. I've made sure that exposure and disease will be artificially linked because I'm more aggressively investigating smokers as compared to non-smokers, right? And there are many, many, many examples like this. For example, pathologists were more likely to use the word alcoholic cirrhosis in their report when they knew that the patient was an alcoholic, right? They've seen or read that the patient consumes alcohol, then they're looking at a slide that's okay, this is alcoholic cirrhosis, right? That's a bias because they should have been blinded when they read the slide on whether the patient was alcoholic or not. But if you don't blind them from the exposure status, it could influence their outcome measurement, right? And confounding, we already saw, endlessly in this course, because unlike a randomized trial, nobody is randomly allocated to anything in a cohort study. And you can take it for guaranteed that those who are exposed will be very different from those who are non-exposed on a whole bunch of different variables. And the only way to handle that is in the analysis stage. So you have to measure the confounders and you have to do regression models to adjust for confounding in your analysis. And here is a beautiful illustration to kind of wrap this up. So here is a large cohort study. I believe this is the nurses health study, 10-year follow-up on postmenopausal estrogen replacement therapy, hormone replacement therapy, and cardiovascular disease. They found a very important reduction in coronary artery disease among nurses who took HRT versus those who didn't. They did adjust for confounders in this cohort study, and for a long time, everybody thought this was the answer, right? And you can see in this study, they adjusted for age as well as risk factors, right? Diabetes, hypertension, oral contraceptives, time period, whole bunch of covariates were adjusted for in this cohort study, right? So it was a thoughtfully done good cohort study. But in the end, when the first randomized control trial was done on HRT was actually found to be harmful, right? It increased the risk of coronary artery disease in postmenopausal women. The whole field got shook up because it completely shattered everything that we had learned in a cohort study. And the biggest issue here is randomization completely removed confounding. Look at the beautiful comparability of women who are randomized to estrogen progestin versus placebo, right? If you go back to a cohort study, no matter how hard you try to adjust for confounding, you will not have adequately adjusted for confounding, right? Because there are unknown confounders that you can't adjust for, and there are confounders that are poorly measured that you may not have adequately adjusted for, and the sheer act of randomization produced spectacularly comparable groups. That's why we are confident that HRT now is considered harmful rather than beneficial, right? Completely opposite conclusions of what the cohort study showed us. And if you want to know more about this, you can read the bias case study that we published, right? And the last slide is to say, okay, how do you read critically cohort studies? Well, ask yourself, who is the cohort? Who got into the cohort? Who stays in the cohort? How well was the exposure measured? How was the outcome measured? Was the outcome measured independent of the exposure status without the information bias? Were exposed and unexposed people tested in the same way and not tested more aggressively if you're exposed versus not? Was the follow-up period long enough? And was confounding adjusted for in your analysis?